Somebody keeps muting me somehow. I don't know how, but you are. I'll tell you this, when I was listening to genetics, I felt like we've really, really covered a lot of genetic stuff that she talked about. So if you've been present for those sessions, I feel like we've hit a lot of those points. I was hoping for more in the hematology section, but yeah, I think we're good on genetics. We are. Skin we can go over again. I feel like we've hit a lot of those points. And then when she was talking about the hematology, I was going over it and I'm trying to think, like, she does cite a lot of the tables that we've focused on, so that's nice. But what I don't have, and it drives me nuts, is better ways for you guys to remember stuff. Like, I don't have charts, and I don't know how we're going to be helpful today other than talking about stuff. You know what I mean? Which I just hate that feeling. But let's just start going over some stuff and see. She pointed out some stuff that I've never focused on before, so we'll just read over it. And if you guys, I took only a little bit of notes. I listened to it in bits and pieces today, and sometimes it was when I was, cleaning my house because I wanted to listen to it before the session. So if you know that we're off track on something she said wasn't going to matter, or we skipped something that she said would matter, and you feel we need to look at it, then just tell me. You guys know I'm always open to whatever it is that helps you. Again, in numbers, we're going to focus on numbers, right? But if you'll notice, she actually said the same thing I say all the time, is the did you understand at the last part of the chapter, to read it. And it summarizes things so nicely as a quick punch review, right? So starting on chapter 20, which is page 490, so let's see. I'm going to skip over a lot of it. It's single questions, right? Single questions here. Components. That's a little bit of a review for you guys, right? You know what? One thing I would read over, just because we keep going over it, and she went over it in the review a couple of times. I know you're going to read everything on here, or at least skim and do your blue terms just to get an idea. But the spleen, if you notice, we keep talking about the spleen in these chapters. Like, it is the one thing that keeps coming up again, right? So on 494, it talks about it a little bit. And of course, we're going to talk about it in our sickle cell anemia. I don't even remember what else later in the chapter. So this is going to come up again. It's a very, very, very vascular organ. All right, sorry, that was like a pit stop when I was going forwards here. And you guys know that this is a lot to read, these sections, for one question each. So as much, when you focus on this, as much as you can just compartmentalize it and squash it down, the better. Sorry. Where is it? Alterations with aging is where I was heading towards. Perfect. So the first thing, and we're not going to sit here, right? Because this is literally not even it's a couple paragraphs and not even, right? So the alterations with aging on 511, she's telling you there's definitely a question here, right? So if you can write out the little things in here that change with age and remember them, you're gonna get the question right. Worst case, if you need to refresh it, looking at the did you understand, little change with age, erythrocyte replenishment delayed after bleeding, lymphocyte function decreases with age, decrease in cellular immunity, and platelet adhesiveness increases with age, but there's actually no change in the platelet numbers or structure. That's on 511, and I was also pulling from 512, kind of just summarizing there. Not the end all be all, but a few main points for that. You guys know there's a question in there. I know we skip the one question ones a lot, just playing the numbers games, but when it's only a couple of paragraphs, it would be beneficial to pay attention to that one, right? Sorry, I have all these other things running. There we go. There. There is. And after the first semester in tutoring this, one of the big things that I realized that I can be helpful with after seeing these exams and how people do, and then looking through the book myself is a lot of it's strategy, which is also going to be on your NCLEX. You have to use strategy when you're taking that test. All right. So alterations is what I'm looking at here. So we know there's 8 questions under alterations in hematologic function. We also know that's an entire chapter, so really? Shannon, did you send me that? It was just the link for the tutoring, right? Okay, I missed the PowerPoint part then. I'll have to look. Link to the, oh yeah, you did. I'm sorry. Okay. I've only gotten to look at it a little bit, of course. They're similar, yeah. Well, and a lot of these don't change. They only change a few questions each semester, but as you can imagine, it kind of gets further away. But at least you see what types of things they're thinking, right? Yeah. Let's see. So guys, for those of you just joining, I just see things popping up. I don't know if it's your first time joining or if you've been popping in and out because of whatever. We're on page 513. Getting into alterations in hematologic function, which of course is a massive chapter, right? Starting with alterations of erythrocytes. So, of course, we'll be talking about anemia here. How do we want to do this? Now, I'm pretty sure that she mentioned 21-1 on page 514 as a good table, right? And we've been talking about this table in our sessions as well. It gives nice summarizing facts, right? And what I had recommended on this was to also do, like if you rewrote this by hand or on the computer, like whatever helps to commit to memory for you, because I know for me, rewriting and doing stuff helps me to commit it to memory, is adding that extra column in with the signs and symptoms, right? So that way you're thinking macrocytic, microcytic, normocytic. You can remember maybe what was in your chart in each place. And then the major signs and symptoms. What did I write down the other day that I felt was helpful? Or did I not bring it? So I would do it for each anemia, right? Is the thalassemia in the kids part? because I know we talked about it, but I don't remember what part. It may be in the pediatric chapter, right? I know it's in here somewhere because somebody had a lot of good questions on it when we were talking the other day. So it's somewhere. And I just don't love the way that this book is written a lot of times. So we'll kind of go back and forth here. But in looking at this here, right, we were talking about these things the other day. It is in the pediatric? Yeah, okay. That makes sense because I think we went over sickle cell after that too. So when we're looking at pernicious anemia, right, just by its name, they say that it got that name because of how deadly it was way back when. So I would take out some of there's a lot of manifestations, but if you can summarize just a few things, let's see, what would I pick out of here? Let's because you have two that kind of have gastric symptoms. So I'm trying to think of the best way to do the iron deficiency, folate and pernicious separately, right? So if I was going to write down pernicious anemia, classic symptoms, weakness, fatigue, which is pretty much all your anemias, right? Paresthesias of feet and fingers, difficulty walking, loss of appetite, abdominal pain, weight loss, and a sore tongue that is smooth and beefy red. That sticks out to me because when we're talking about iron deficiency anemia on the next page, which you don't have to flip to it yet, but there's actually pictures of somebody who has a different type of tongue for their iron deficiency anemia. So pernicious anemia is the smooth and beefy red tongue, of which there is no picture, as well as those other kind of a little bit of GI symptoms, right? Abdominal pain, loss of appetite, weight loss, and a sore tongue that is smooth and beefy red. They could have yellow skin, which is a combination of pallor and jaundice, and then hepatomegaly, right? So if you're going to group all those things together, if you have an enlarged liver, you're probably going to have some issues with jaundice, right? There's some problems going on there. You can put those two together. And right-sided heart failure. All right. And then I would put neurological manifestations along with that as well. And again, remember that was the one that was pretty fatal. Pretty fatal being fatal back in the day. So with the folate deficient, right? So now we're talking about a different B vitamin here. And it even says on page 517 that clinical manifestations are similar to the pernicious anemia, but specific manifestations to folate, chelosis, scales and fissures of the mouth. I'm probably saying that word wrong. I've never said that in my life before, okay? Except for this class. Stomatitis, which is inflammation of the mouth, painful ulcerations, and tongue characteristic of burning mouth syndrome. Okay. So a lot of these have similarities that seem to be exhibiting themselves in the mouth. So burning mouth syndrome is going to be folate deficient anemia. And then we get some more GI disturbances for folate deficient anemia. Dysphagia, which whenever you see, I know this is kind of kicking it into further chapters because you're going to see dysphagia and dysphagia a lot. So there's two words that are very similar. One of them has a G and the other one has an S at the end. So dysphagia with GIA at the end. When you see GI, think gastrointestinal. Okay? So it has to do with swallowing. If that had an SIA at the end, then you're going to think about speech. Just so you can remember that, because you don't want to be writing a nurse's note later and feel really stupid when you put the wrong one. It's a good note. It's how I remember it, because forever I would get them confused because I would think S for swallowing, but it's not. So when you see dysphagia that ends in GIA, think gastrointestinal, GI, right? So I swallow my food into my GI tract. So GIA, dysphagia. And then once we start talking, and it's actually in quite a few chapters that we go over in the future of this class, there's dysphagia that's SIA, and that's speech. So S for speech, and GI is for swallowing into the GI tract, right? Welcome. And I'll repeat that when we're doing that, those chapters too, but might as well learn it the right way as we're going, right? So there's definite GI issues in the folate deficiency as well. Dysphagia, gas, watery diarrhea. And then this can be highly attributed to malabsorption issues in the GI tract. So you'll see that they list lots of things like Crohn's, colitis, anything that's going to interfere with that absorption. There can be neurologic manifestations, but it doesn't really talk about them, so I don't know. You could just know that there could be. All right, so switching out of our macrocytic into our microcytics, iron deficiency anemia. So spending a little more time on here, right? Because the first sentence says a lot. Iron deficiency anemia is the most common type of anemia throughout the world in both developed and undeveloped countries. So what's our patient population? If this is affecting everybody, underdeveloped to developed, it really doesn't discriminate. So who are the people that have this, right? So higher risk, people living in poverty, women of childbearing age, and children. Also, I was saying this last time, not thinking of, this part nursing school. My daughter, when she was going through her first year checkups, they are very, very, very worried about their iron levels, and I don't remember what ages they do it at, but they do finger pricks or heel stick, whatever they do. I think it was a finger prick at this age, and they check their iron levels. And if you're even close to borderline, they really push iron supplementation. And, so talking to the pediatrician, she gave me a little information, went home and Googled it and found out how important it is for cognitive development. So it's a big deal to have low iron, It's not just that you're going to have this anemia. For children, their cognitive development can be impaired. And it says here may be irreversible. So that's interesting, right? For kids in developing countries, so it also mentions that chronic parasite infestations can create more blood loss, than iron intake. So you kind of are losing iron and not taking enough in, so it's a double whammy. What was the other thing I wanted to focus on? Treatment, blah, blah, blah. Oh, here's another big thing. At the top of page 517. So iron deficiency anemia also occurs in individuals with lead poisoning, and treatment is associated with a decrease in lead levels. So if you have high lead levels, your iron levels are going to be low. All big things for the most common type of anemia in the world, right? So remember all those points, write them down. Mm-hmm. Sorry, just seeing how to compact if there's anything. And you guys know, I feel like I always have to say, just because I don't say it doesn't mean it's not important to look at. I'm just trying to make the most of our time. So under the patho, it's talking about how it can arise from either one or two things or a combination of both, and that's inadequate intake and chronic blood loss. And it was just talking about that with the kids, in poverty that probably have parasite infections that cause them to lose some blood. Um, so it can be a combination of both or just one or the other. The other thing that I want to point out here, hmm, I don't know that this has been on this module for testing in the past, but if you'll notice on the second paragraph under pathophysiology, you see H. pylori, right? And if I skipped over it, but if you look back on 516 on the first, it's a partial paragraph on the left side. Helicobacter pylori is a bacterial infection in the stomach. And if you'll notice, it's actually associated with at least two of these anemias, as you can see, right? And you'll see H. pylori come up in a lot of our future chapters as well. So just be familiar with that name, Helicobacter pylori. It contributes to a lot of chaos in the body and a lot of disorders and conditions that are related back to it. All right, so clinical manifestations. Sorry, I know I took a little bit longer on that just because this is the most common type, right? Early symptoms, they're non-specific, and this is what I was saying can be for any type of anemia. Fatigue, weakness, shortness of breath. It starts talking about, and the shortness of breath, of course, is if we have reduced oxygen, right? Reduced hemoglobin oxygen carrying capacity, then we're not getting enough oxygen to places that we need it, right? So we can be short of breath. It starts talking about pale earlobes, palms, conjunctivae. So especially in people that have a darker skin color, when we're assessing them, it's easy to tell on somebody who's very, very fair if their skin's lighter, right? But if somebody has a darker skin tone, those are the places that we're looking, and the conjunctivae, gums, the palms, those types of places. So if you look on the back or on page 518, the glossitis, figure 21-5. So here we're talking about tongues again, right? So this is a patient with iron deficiency anemia, a fissured appearance with the tongue, and the spoon-shaped or concave brittle nails. Kaya, I don't really know. Spoon-shaped nails. So there's your iron deficiency anemia. Also talks about possible difficulty swallowing, which would be dysphagia with a GIA, just like the other one, right? Because of inflammation and mucus at the opening of the esophagus. And then if you really continue to read this, it gives a lot of symptoms that sound like the other ones, right? Gastritis, neuromuscular changes, irritability, headache, numbness, tingling. Happens with a lot of them. So it's hard to pick these apart from each other. So writing them down is great. But also remember the big differences, right? The bald, fissured tongue, we're talking about iron deficiency anemia, right? The beefy red tongue, we're talking about pernicious. For the folate deficiency, they have that burning mouth syndrome, right? Hey, Caitlin. I don't know if you're just popping in for the first time or not, but we're on page 518. You're welcome. Looking at the sideroblastic anemias here. Hmm. How to summarize these. And I should say, not only that, what I'm going off of is page 514, table 21-1. It's the table that we've reviewed. I know you're familiar with it several times. And just kind of pulling out the big signs and symptoms um, for the differences in them. So we talked about pernicious, iron deficiency, and folate deficiency. And now we're on the sideroblastic anemia. All right. So with the sideroblastic, and it puts it in a blue term, ring sideroblast. So the presence of ring sideroblast in the bone marrow, right? That's what tells us sideroblastic anemia is here. And that's iron-laden mitochondria arranged in a circle around 1/3 or more of the nucleus. It's the only one that sounds like that. So just put those two. They obviously have the name in them. Just associate those two in your head, right? So clinical manifestations, we'll pop right over to there. So it says, in addition to the CV, cardiovascular and respiratory manifestations with all anemias, may show signs of iron overload. And that's one of the things that she talks about on the review as well, which is going to be in a couple of pages further. So if you're talking about one of the anemias associated with iron overload, it's going to be the sideroblastic anemia, right? And that's where your ringed sideroblasts are. Okay, so may show signs of iron overload, hemochromatosis. I don't know which word they're going to use, but just know both for your test if it's on there. Sometimes it's only one of the two. Mild to moderate enlargement of the liver, hepatomegaly, right? Megaly being larger, and obviously hepato being liver, and splenomegaly, which is obviously enlarged spleen. Functional liver, let's see, but the skin may become bronze tinted. Hemosiderosis, let's see, cardiac rhythm. Okay. So other than that, this is really, aside from the heart failure mentioned, and I believe pernicious, this is the only one that mentions that if there's hemosiderosis of cardiac tissue, it could result in heart rhythm disturbances, but it's not common and usually a later sign. And that growth and development can be impaired in infants and children. And for this one, I kind of skipped over it in the beginning of it, but the big thing here with sideroblastic anemia, so it talks about a lot of times it can be secondary to other conditions, right? So alcoholism, drug reactions, copper deficiency, hypothermia. So a lot of those things, of course, can be reversed. And what it talks about in treatment is obviously to identify the cause and then kind of work from there, right? Because there's more than one thing. It's not just it feels like there's more options to look at as to what's causing this. And obviously, if it's alcoholism, we need to give them the proper vitamins, right? And take out the alcohol. Or if it's a certain drug that we're giving them, we need to take that out. Just depends. That's probably our segue into the iron overload, right? So we'll come back to thalassemias because that's going to be in our pediatric section. And it looks like we're going to be skipping around because that's how this book rolls. So we'll come back to page 514. She actually talked about polycythemia vera a little bit. So of course, this is a lot of red blood cells being produced, right? And here, for our normocytic normochromics on 514, does it mention them all? Does this have sickle cell? So table 21-2 is a good thing to look at and actually gives clinical manifestations for aplastic, post-hemorrhagic, hemolytic, and chronic inflammation. Sickle cell, we're going to talk about more anyway. So this is a good table. I'm not even going to go over the rest of those because table 21-2, it gives you those clinical manifestations. I would pull from that. Just looking at it, see if there's anything specific I want to say. I don't think so. All right. Did I write anything down about polycythemia vera? I don't know if I was writing stuff down when she was talking about that. That I had that written down here, and then I also wrote some other notes that I did this the other night when you guys first sent it to me, and I'm like, what was I writing here? I'm trying to relate it to something I'm looking at, and it doesn't. I see the JAK2 gene, but I don't know what some of this other stuff means. So I'm going to have to leave that part out. I definitely have the JAK2 gene written down as well. The other thing I have written down, just pulling stuff out of the text to go over, hyperplastic and neoplasms, bone marrow alteration, right, when thinking of polycythemia vera. High RBCs, WBCs, platelets. So if you think about this, obviously if we're adding all these cells in, right, like there's this overabundance of cells, the blood is literally thicker, right? Very, very viscous. So high viscosity. When you have all these cells and platelets and everything going around, you're at much higher risk for coagulation. Okay. Higher risk for coagulation is a higher risk for clots. Right. Your book on the bottom of 521. So when it starts talking about circulatory alterations, just from the process I was just talking about, it mentions manifestations such as plethora, which is a ruddy red color of the face, hands, feet, ears, and mucous membranes. So kind of just a ruddy look. Like I can picture people in my head that look like that in general. So with that thick blood going around, it does list, I don't think I wrote down these, but headache, drowsiness, delirium, mania, psychotic depression. I can't explain that from this, but chorea, which remember, chorea, I don't know if you guys remember this word, but just to throw it back to the other chapter, do you remember what disease we talked about in genetics that lists chorea, the uncontrollable, the limb movements? as a symptom. Huntington's. Good guess. Angelman has that ataxic gait, so that's why you're thinking of that. So good. This is Huntington's disease. Exactly. Good, guys. And the dementia-like symptoms as well. So yes. All right, so chorea and visual disturbances. So enlarged spleen and abdominal pain and discomfort. If you have this thick, sludgy, for lack of a better word, viscous, right? Okay, viscous will be appropriate. Blood coursing through your body. Remember that spleen is like, it's a reservoir. It can hold a lot of blood in it, and it's very difficult for it to move through if it's that viscous, right? So the spleen can become enlarged very easily. Abdominal pain and discomfort. So death, here's a big thing, right? So if we have this thick blood, high coags, easily to clot, cerebral thrombosis is a great risk. So approximately 5 times greater in individuals with polycythemia vera. Oh, I wrote down one more thing out of here. So if you flip to 522, the second paragraph, I guess I should skip before that. There may be Raynaud's phenomenon, which is like the clamping down in the fingertips. They become white, very cold. But right underneath that, this is a unique feature of PV and helpful in diagnosis. So this is the only thing that I've read that, it doesn't attribute to lots of these other disorders that we're reading of. So this stands out to me. It's an intense, painful itching, appears to be intensified by heat or exposure to water, especially warm water. And they mention when bathing or showering. So that's interesting. So with PV, intense, painful itching, and it's intensified by heat or warm water. Is there anything else I want to say on that? I don't think so. So she did talk about iron overload a little bit, but really not much, right? Just talked about it, hemochromatosis, unless I missed it, which is of course possible as well. So how can we, let me see how long this is. Looks like it mostly just talks about the hereditary, right? So we'll mostly talk about hereditary, but it's talking about the secondary cause. List a couple of things: dietary, certain anemias like sideroblastic, which remember that had the iron-laden mitochondria, right? And aplastic anemia, or conditions that require repeated blood transfusions or iron injections. All right, so with hereditary, so if I'm thinking of this, I would mostly be focusing on hereditary because it's the biggest part, but of course she can pull something out of that one paragraph if she wanted to. But hereditary is excessive iron absorption. Right? She wants to know, how does it occur, signs and symptoms? What's a good sentence here? This is too much. So you already know that it's excessive iron absorption, right? So we'll just leave that. That's obviously something that's going on in your genetics, okay? It actually says, I believe it says something about the autosomal recessive disorder of iron metabolism. Hereditary? To be honest, I do not know. Is that a part in here? I only see race. Yes. So it is males more than females. It doesn't. I was gonna say I don't remember. Bottom. Try and find something that makes it unique. Well, at least it's the only iron overload that we really talk about, right? And we were linking that back with the sideroblastic anemia, and it also says aplastic anemia. So connect those two, and then it talks about the iron causing tissue damage, okay? Cirrhosis, diabetes, heart failure, arthropathies, and impotence. Oh, and here it is, affects males more than females. I see what you're talking about. Sorry, I did not remember that. I wouldn't worry about all of these little statistics under that. That's a lot. I would say the big things there are the organs that it can affect, right? So other than that, with knowing how it happens, link it back to those two anemias in your head, okay? And then other than that, so fatigue, malaise, abdominal pain, gosh, at that point, it can be any of our anemias or this, right? It could be anything. Arthralgias and impotence. Oh, I'm trying to find something better here. There's really not much more in here than that. So I would really put what it can cause, like cirrhosis, diabetes, heart failure, arthropathies, and impotence. Cardiomegaly. Yeah. Sorry, I was. I know there was failure. It might be the first one with an enlarged heart. Like I know there's heart failure, which sometimes can go along with it. But I don't think it mentioned cardiomegaly specifically. Right? They all have cardiac effects. I know that. But this is actually your iron overload. I just can't help but think that if she's going to talk to you about this, that I would just completely group it differently, you know? Really don't have anything to compare it to. You can link it to two of those anemias, but it's just totally separate. You know, so if you can remember that it's going to be very similar to a lot of our anemias, it's going to give you liver issues, you know, like cirrhosis, diabetes, cardiomegaly, so it can affect the heart. The impotence is interesting. I really don't have anything to remember that, but nobody else has said that, you know. So just try to group it away from your anemias. It's something just separate. Put it as something separate in your notes. Yeah. Yep. And there can be some skin pigmentation too, some bronze coloring. Yeah, there's somewhere, I forget which one it is, was for younger guys, but a lot of the anemias, I feel like women are definitely more prone overall, but they always have some weird caveat to make it confusing, right? Leukocyte function. Isn't this so much for 8 questions, guys? And we're not even halfway through it. Uh, What are alterations with leukocytes, signs and symptoms? she mentioned this table. What I would do for this part, honestly, I do not have an easy way for this to be remembered. I just don't. It's table 21-4. It's on 524. She pointed this out in the review too. I really don't. Hmm. Whenever I see eosinophils, that parasites thing comes into my head from the other chapter, remember? Let's see. So every time I see them, that's what I think about. It's the only thing that really stays in my head about them. Um, well, I'll tell you, so this is interesting to me. And not knowing what this current, yeah, it was one on the last test. I know. I didn't know if they changed it, but so this is interesting to me. So, and I truly don't know, but what I did hear her say in the review, she talked about this table, and then she popped over to, oh, sorry, my husband left the garage open. Hold on 1 second. Where's my phone? Please shut garage. Okay. Sorry, guys. I was going to do this tutoring session outside because it's gorgeous here today. Like, the only reason to live in Florida is a day like this. But they're doing construction next door, and I hear it in this room even. It's so loud. I was so bummed. Okay, so back to this. So she talked about this table, and then I felt like it was almost a little random. She jumped onto infectious mononucleosis, which I haven't honestly spent time on in the past. But I was like, okay, well, is this a change? Is this a new question? And I don't know, but I did pick up on that, right? Um, in the lymphocytes, if you're looking at lymphocytosis, it actually mentions infectious mononucleosis in this part. So as far as this table goes, I don't even know how I would. I don't know what I would focus on for it. Um, so there's so many different things that can cause these. It's the problem. Remember your endings first of all. I just want to say that. You know, when it's ending in like ILIA, it means like it loves it, so lots. Um, and then penia is going to be small, right? So you're talking about lots of things and little things, like lots of neutrophils and little neutrophils, right? If I, this is not in any way based off your test, but personally, when I'm looking at this stuff, like neutrophils are the biggest thing that you're going to deal with in actual nursing, it feels like, on a daily basis. Nobody's like, what's their basophils, you know? Like, because neutrophils, if you're getting a lot of baby, um, if you're getting a lot of like baby cells, like you're thinking, oh, it's a fever. It's a lot of baby neutrophils, you know? A fever. It's an infection. Like maybe we do have an infectious process going on because lots of things can make your actual white blood cell count jump up, including stress. So I can't think of a way to shrink this for you, unfortunately. But maybe just looking at the causes, right? That's the only thing I can think of. I'm sorry. And then just because she mentioned the infectious mononucleosis, now it's not on here. So is she just saying that because you guys know everything that she talked about in that review isn't necessarily on the test because it was so broad still. But it just made me wonder about this. So if we're here, alterations with leukocytes. So now we're here. No. So it says benign, acute, self-limiting, lymphoproliferative. Oh, that's too much. Characterized by acute infection of B lymphocytes. Most common is Epstein-Barr virus. And you'll see a lot of people that come in with really chronic, like they just can't shake it. They have all these symptoms. They feel like they've been sick for months and months. They'll test them for the Epstein-Barr virus. So other things that can cause mononucleosis, it talks about cytomegalovirus, adenovirus, which is really common, HIV, Hep A, flu AB, and rubella. Also toxoplasma, interesting. Diphtheria, okay. So anyway, because they like the signs and symptoms, right? So pharyngitis, lymphadenopathy, and fever. So I don't know if you guys had like mono outbreaks in your schools when you were younger, but I feel like there was always some kid that was getting mono. Never personally had it. But they actually called it or call it the kissing disease, right? So transmission of Epstein-Barr virus usually through saliva and from close personal contact. Oh, it even mentions it. Kissing, hence the term kissing disease. Can also be secreted other places, genital, rectal, respiratory tract, and blood. And again, it says it here, the infection begins with widespread invasion of the B lymphocytes. What else do we want to put in here? How can we summarize this? This one caught me off guard when she was talking about it. I was like, oh, okay. So flu-like symptoms, we already talked about some of those. It does mention cervical lymph node enlargement, pharyngitis, lymphadenopathy, enlarged spleen, and usually self-limiting. We're not going to go into those. Those are the little things I pick out of there. Unless you guys see something else to add. I mean, I kind of skipped over the more severe things that can happen that are rare, but the quick check questions. And I think she was mentioning that too. Those are always good to do. Classic symptoms, yeah. I think that's a really good summary. That, and then of course, always the did you understand, right? Always the did you understand. Let's go forwards because there's so much to cover here. So gosh, I don't want to skip over too much here. So we're getting into the different leukemias, okay? I'm not going to go into all the leukemias, right? We know that's a cancer of the blood. The book says clonal malignant disorder of bone marrow and usually, but not always, of the blood. Mm. Of course, there's different types. Um, Another word to look at, and of course, I'm on page 526. If you look at pancytopenia, ending in PENIA, right? So if you get a test question, you just can't remember what it means. Remember your prefixes and suffixes. Reduction in all cellular components of the blood, pancytopenia. Whenever we get, I don't work in oncology, but every once in a while we get an oncology patient, right? If there's no room in the other ICUs, because I predominantly work in trauma. But you get these patients and their blood counts are insane, like absolutely crazy. I remember one guy was a new diagnosis. I don't know what type of blood cancer he ended up having. They found out that day his blood count, his white blood cell count, which is normally, I don't know, maybe it's on the higher side of normal would be 11,000, was like 173,000, like something crazy. Like they had to filter his blood out to get the white blood cells out because it was going to end up killing him, So it's just, or they're incredibly low, like the pancytopenia, they're all low, or maybe just it's neutrocytopenia, like it's just neutropenia. But their blood counts are very crazy. Which I did notice. She said that you guys don't have to memorize the values. That's great, because that probably would have been a lot to focus on. So remember, if you guys didn't watch her review yet, she did say you don't have to memorize the values for the blood counts. I'm going to move on to lymphadenopathy. She couldn't say that word either, in my defense, when she did the session. I don't know if you noticed that. I didn't feel alone anymore after I saw that, though. All right, so signs, symptoms, causes. Yeah, that's a tough one. So I feel like I have another note that I wrote down for this section, but do I have it? I have so many notes for y'all stuff. It's crazy. Talking about lymphoma. All right. So lymphadenopathy, characterized by enlarged lymph nodes. So why does it occur, right? That's our next sentence here. Causes: increase in the size and number of its germinal centers caused by proliferation of lymphocytes and monocytes or invasion by malignant cells. Right, so we have some sort of an infectious or neoplastic process going on, right? Okay. So in that second paragraph on page 531 at the bottom, under that section, here we go. So she started talking about this, and it has definitely been something I've reviewed in the past, so I'm going to go over it. But it's almost to the bottom. It says generalized lymphadenopathy occurs with non-Hodgkin lymphomas, chronic lymphocytic leukemia. Okay, what I was really getting at was the lymphoma. So generalized lymphadenopathy occurs with non-Hodgkin lymphoma. She was talking about non-Hodgkin's versus Hodgkin's lymphoma. Right, so generalized is non-Hodgkin, right? Generalized. Okay. Yes, Reed-Sternberg cells for Hodgkin's, exactly. So that's your other difference there. So if you have the Hodgkin's lymphoma, you have your Reed-Sternberg cells, the RS cells. And there's a picture of them on page 533. So non-Hodgkin's lymphoma is the generalized lymphadenopathy. Ouch. Like that's going to be my difference, right? And then what I would put under the Hodgkin's lymphoma is the Reed-Sternberg cells. Exactly. All right, we're not doing that. So lymphoma, most common blood cancer in the United States. Probably why it's come up a couple of times in the past, right? So here we have another most common. Can happen at any age, doesn't matter. I think that's in another paragraph here. Early 1970s. All right, I thought that was going to give me something else, but I guess not. Okay. So looking at Hodgkin's lymphoma, we already talked about the Reed-Sternberg cells. And you can see a big picture here of enlarged cervical lymph node. Pretty obvious right here, right? On this person. What your book says under clinical manifestations that unlike non-Hodgkin's, which can be generalized lymphadenopathy, the most common places are cervical, axillary, inguinal, and retroperitoneal lymph nodes for Hodgkin's lymphoma. And then there may be systemic symptoms, fever, with or without infection, night sweats, itchy skin, and fatigue. I'm on 533, clinical manifestations, first paragraph. That's asleep. There we go. Jumping over. Oh, here's good. I remember we talked about this table in another one of our sessions. Page 535. I did see that it mentioned some anemia, often found with low serum iron and reduced iron binding capacity. If you guys look on 535 at the top, table 21-8 does a really nice clinical differences between non-Hodgkin lymphoma and Hodgkin. So it's talking about the lymph nodes. So the nodal involvement. Non-Hodgkin's, we already said generalized, multiple peripheral nodes, right? She mentions 21-13 too. Oh yeah, that picture. I don't really like that picture. But if it helps you, you should look at it, right? Multiple versus localized in Hodgkin. Yeah. That picture is just for Hodgkin. And I would focus more on the common sites, but that's just me. No, the picture's not great. I really don't like it. I'd rather have like a table, you know? I'd rather have a table. But I will say in that table 21-8, I would know the ones that we just went over, right? Like the most common ones that we just went over in the paragraph before. But also what it says here, there's mesenteric nodes and Waldeyer ring, and they're rarely involved in the Hodgkin's lymphoma, and they are commonly involved in non-Hodgkin lymphoma. So if she wanted you to be familiar with lymph nodes impacted, to me, that being in the table kind of sticks out, but I would still know what it says the main ones are, right? Sorry. Um, and then it talks about, of course, same concept, extranodal involvement common in non-Hodgkin and rare in Hodgkin. Hodgkin's often localized versus non-Hodgkin lymphoma. It often spreads, rarely localized. What else do we want to say about non-Hodgkin? Because we did more. Various clinical manifestations. No. It references table 21-8. And its most common are cervical, axillary, inguinal, and femoral lymph node chains. Some overlaying similarities with Hodgkin, correct? Hmm. Thought I found a difference, but I don't think I did. So note that all these swellings are typically large, painless, swollen nodes, right? Versus a lot of times with infection where you palpate your nodes and they're incredibly painful. Anybody else see any differences we should include on that? Hepatomegaly, splenomegaly. Yeah, cytopenia, often observed. I'm right below it. I'm just looking through the clinical manifestations, trying to pick it out. She did point out the Burkitt, because she had that firefighter story, right? She did point that out, and I haven't reviewed that much in the past, so I found that interesting. And remember, she actually talked about the Burkitt because she had the explanation of the story about the firefighter that came in and how fast his grew. So she actually reviewed that probably more than any of the other topics in that review, right? Um, Pretty interesting. See if I have anything to add to what she said. I don't really think I do. So the book does say that it's typically a large tumor mass in the jaw and sometimes the abdomen. And that's exactly what the picture is. I know, and I don't know. I'll tell you, it used to be that people would get the blueprint and everybody hated the blueprint, because they're like, it just doesn't narrow it down. And then they would do the review and everybody was, just, they felt like they got more from it. So I don't, they switch things around all the time. And it, of course, depends on the people too, like what you get from it. But I know this is still so much. And we'll see. You guys should compare what you write down from her review to what you remember being on the test. That way you can say, is that really pointing us in the direction or not? You think so? Seriously, the thing that I got from this was I think we've done really well in reviewing, definitely for genetics. And skin is a little rough, but at least there's no burns, most likely. She did highlight pressure ulcers a lot, and she talked about the children's conditions that are mentioned more than once, right? Especially the ones that are in both places. So I know. Well, Burkett. What I'd remember, this and more at least, is that it's jaw typically, sometimes abdomen. I think it's mostly out of Africa, but it obviously is other places. Um, as she explained, that it's something that can happen very fast. Um, I don't think I'm going to add anything to it. Since she highlighted that, is why I was thinking we should go over it. Let's see. So for the types of lymphomas, I don't think I don't think that there is a good table for that, unfortunately. Maybe she just meant Hodgkin's, non-Hodgkin's, Burkitt. Maybe that's enough for it, right? So here's one. So alterations in splenic function. I remember when we first started this review today, we just pointed basically to that section on the spleen. But it, of course, keeps coming up here. She took time to focus on it, right? So 538, splenic function, risk factor, signs, symptoms, complications. So, and she talked, did she talk about complications of not having one? Like, did I make that up in my head? I don't know. So normal functions of the spleen, right? You don't recall that? Yes, okay, all right. Something close to it, right? She kind of, and when she touched on that, it kind of sent a light off in my head. She alluded to it. That's a good way to put it. It was something where I was like, okay, you know. So we'll look at that, okay? Um so phagocytosis of blood and particulate matter, right? Bacteria. So destruction of blood cells that need to be destructed. Okay. So getting rid of all blood cells, whatever other matter, antibody production, hematopoiesis, sequestration of formed blood elements. Remember that um, the spleen is so vascular and it can hold a lot of blood, right? So with it having all of these functions, when there's an alteration in function, these are what can be altered, right? So either if I didn't have a spleen or I had problems with my spleen, then I'm not going to have the red blood cell. Like my blood cells are not going to be cleaned out like the spleen does, right? Um, or particulate matter. And it gives the example of bacteria. My antibodies, I'm going to have a reduced immune response, right? Hematopoiesis, I guess, depending on your age, maybe issues with making red blood cells. And then so when we talk about the, oh my gosh, sickle cell, a lot of times those cells kind of clog up. The wrinkled RBCs. What were we talking about with that? And we were like, what's a wrinkled RBC? Was it this part here? Or was it over in sickle cell where they use that term? And I was like, well, I don't really know what they mean by that. 540. Okay, it was right here. So funny. Yeah, I guess it can't remove it, right? Okay, so just if you can remember those four things, then you can know what can be affected, right? So, hmm. So in box 21-3, I don't remember if she mentioned this box or not on the same page, page 539. Um, just to give you an idea, is that can be related to an enlarged of diseases that can be related to an enlarged spleen, right? I don't know that you need to memorize that, but a lot of those are going to make sense, right? Like looking at tumors or cyst for malignant has polycythemia and a different type, but a type of polycythemia vera. And you already know that that blood is viscous and thick, right? So imagine that moving through the spleen. So that can enlarge the spleen with all of that viscous blood. Um, just something to look over. Unless she said to memorize it, because I don't remember. Um, it also mentions acute inflammatory infectious processes can cause splenomegaly because of an increased demand for defensive activities. Remember, we talked about immunity, right? That's fragile. They are really vulnerable to blunt trauma. That's something that's mentioned in the page 540 at the top. Really, really vulnerable to blunt trauma. And when you have a splenic injury, you are at risk for hemorrhage. Like it could be life threatening. Um, where was that wrinkled part at? Right side? Oh yeah, because after splenectomy, now it's all coming back to me. I remember. Okay, I'll come back to that then. So if you'll notice when we're looking at page 540, now there was that little table or the box, whatever, on 539. But the two things it really focuses on are congestive and infiltrative splenomegaly. So if I was going to really focus on that, that's what I would look at. Congestive, accompanied by ascites, right? So that's all that fluid um, everywhere in the belly. Portal hypertension, they're talking about in the portal veins in the liver, and esophageal varices, most commonly seen in those with hepatic cirrhosis.
Electronic art.
Hmm. And then what it says splenic hyperplasia, which it references on the other page. Basically, the spleen is in high gear. I don't really know how to say it. The splenic workload is increased. It says it well right here. Associated with most various types of anemia, like hemolytic. So imagine if all your RBCs are being destroyed, or maybe they're wrinkled. I don't know, right? And it's got to clean all that up, right? And chronic myeloproliferative disorders like polycythemia vera. So we were just talking about that from the other box. That viscous, thick blood and lots of it, right? So the spleen's going to be in high gear. Infiltrative splenomegaly. So engorgement, storage diseases. And it's really going with tumors for this. I'm going to kind of skip over that, but they cause actual growth of the spleen. So clinical manifestations. Okay. So in talking about that, we've talked about sequestering. So that's, of course, just keeping everything in there, right? So sequestering of red blood cells, granulocytes, and platelets results in a reduction of all circulating blood cells. And it says it may sequester up to 50% of the red blood cell population. That is a lot, right? All right, so the more blood that's flowing through it, the more blood that pools. All right, so that can give you anemia. All right, we'll go with that. So it mostly talks about sequestering in the clinical manifestations. Then under treatment, it talks about a splenectomy, right? You don't always have to have a splenectomy, but sometimes you do have to have a splenectomy. So, as she alluded to, do I want to cover anything before I cover that? Hmm, no. All right. So, what it does say is people can live normal lives. Here's our wrinkled. Cell abnormalities often exist after removal of the spleen, and it gives examples, which include our wrinkled RBCs, right? Um, White blood cell counts initially increase, and platelet counts rise after surgery and then stabilize. And I think I told you that a lot of times in our patients that are trauma patients that have to have splenectomies because of hemorrhage, um, that a lot of times their platelet counts are through the roof in that acute phase, like well over 900,000, sometimes a lot of platelets. And then WBCs are elevated too, but they have a lot going on. So who knows what that's from, really. So, anyway, so you're thinking about the spleen's not there, cleaning all those things out. So you can expect those to be up, right? It keeps talking about, this is the second time that I've kind of grazed over it. So there's another place in the spleen area where it's talking about post-operative infection. So infection's a huge risk, obviously any surgery, but when you take your spleen out, you're losing a lot of your immunity, right? So you're at a higher risk for infection if it has to do with the spleen being removed. I'm surprised it doesn't say stuff about you have to be revaccinated after this for a lot of things, but it's not mentioning that. So don't worry about it. Doesn't matter. If it's not your book, it doesn't matter, right? Not for this test anyway. I think we've covered spleen well. We covered what she alluded to as well, so I feel good with it. But if you guys have more questions, let me know. Now we're in hemorrhagic disorders. I know it's so much. I know. Like I get tired just talking about this with you guys for 2 hours. Like no joke. After this, I'm like done. I just don't want to think anymore. And I always have these high hopes of like making these tables that would help me and then helping you guys. And it just doesn't. I'm just, once we do this, since I don't have a test on it, I'm like, you know what? I got to shut my brain off. And so I don't get it done. All right. So now, interestingly enough, this is the only place that I've noticed under this section where she says signs, symptoms, risk factors, and teaching. So that she specifically put teaching in here. Is there a reason for that? I don't know. Maybe, right? But how can we summarize this? Sorry, guys. All right. $5.51. Yes, and then I noticed she said something else too that I want to make sure we get to. Hold on 1 second. Let me see if I have something here. Okay, I don't. So that's not helpful then. All right. Let's look at that and see if that'll help on 551 rather than. Oh, I know. On our, I remember her saying that. You're right. In the did you understand? Yep. I remember her saying that specifically for this section that it was really summarized well. So for those of you who didn't watch the video, as always, the did you understand is one of my favorite parts, but especially for this, she said that this is really helpful because it mentions all of the different conditions, right? The other thing that she mentioned was on page 548, and I know I'm skipping forwards a little bit, okay? Before I do that, because she did mention the did you understand for this on 551, the one thing that I really, let me check my other notes here. I'm sure I brought the wrong thing, but there's one thing that I'm thinking of. Oops. Well, we need to make sure we go over the hemangiomas and stuff in skin if we get there again. Remember, she was talking about that specifically. All right, what I'm looking for is not here. That's okay. So the one thing that I do want to say is if you're looking at these disorders of the platelets, and then I'm going to pop forwards, and if you look on page 540 at the bottom, it has these terms in blue, right? Petechiae and purpura, which to me both equate to different types of bruising, like, oh yeah, the pictures, yeah. I heard her say that too. She does like to put pictures on the test, and I think somebody asked that last week. Let me see if I can get a good picture here. She likes to put them for sure. So I want to go over the hemangiomas more if we get time. Oops. So what I was trying to pull up here is a good visual of the difference between petechiae and purpura, right? Because if you look at a lot of these thrombocytopenia disorders, it talks about petechiae and purpura. So purpura it looks a little more severe, right? It can be palpable. Let me just put this on here. This isn't the end all be all, but at least it gives you a visual. Do I think that they're gonna sit here and ask you the difference? No, I think you need to know that in like a lot of these thrombocytopenia things, that you can see petechiae and purpura. Okay, petechiae is a little less, purpura can be palpable. It's a little, it's more severe looking. And then, of course, ecchymosis is bruising, right? So it's kind of, in my head, it's like small, medium, large. And that's really generalizing it, right? But when they're talking about petechiae and purpura, that's a good visual. And the reason that made me think about that is on the bottom of page 540, which I don't think that you need to know this table. She didn't mention it, and I just, but I will say it's not a bad one to look over because it's just talking about hemorrhagic disorders in general. And if you're even just looking at defects of primary hemostasis, so it's talking about the bleeds, right? So petechiae hemorrhage or purpura is greater than 3 millimeter red purple discolorations. So there's your true definitions, right? Common in capillaries also includes epistaxis, which is a nosebleed, GI bleeds, and excessive menstruation. So if you have somebody that has some sort of thrombocytopenia in general, right? Those are some pretty good things to look for that could kind of point you in the direction of that being the problem. And then what I want to do, I know I'm skipping a little bit of this. And again, remember your prefixes, your suffixes on the test, right? Do not just flipping through, like reading the section on thrombocytopenia, which of course is little, and thrombocythemia, which is going to be a lot. Remember that. Don't let that throw you off in the test. Like, make sure you identify which thing it's talking about, and don't let your brain flip it to whatever you're more familiar with, okay? One thing that she did mention was the Virchow's triad on page 548, which I thought was interesting because she didn't put it on here, right? 544 and 545. Yes, I agree. Picture, which picture? On 548? 21-20. Yeah. I think 544 and 545 have huge, like, I love DIC, disseminated intravascular coagulation, just because it's a working in critical care. Like, I don't want somebody to be sick, so please don't ever take it that way. But if your heart stops, if you have DIC, like, I want to be the one to fix you. You know, that's what it is. I don't wish it on anybody. Obviously, I'm there because I like it, right? Yeah, she did mention that a lot. I think you're right that these are both really important. There's actually, so I have a coagulation system video, but it's so in depth. Like, I don't think I'm going to share it actually. But it talks about why things like vitamin K and calcium and stuff are important for coags. But it's too much. It's really too much. But there are a lot of good videos for that if you wanted to just look at the coagulation system. The one thing though that I was saying on 548, Virchow's triad. Where is Virchow? Oh, here it is in blue at the top. So on the right side at the top. So I thought it was funny because I do remember reviewing this in past classes, right? But I didn't see it on this, but then she mentioned it. So is she mentioning out of habit, or I don't know. But we actually talk about this in other chapters too. So I don't know which one it is. So there's a nice thrombus picture that she did point out, figure 21-20, that you can see there. Looks pretty gross. So that's actually a clot in somebody's vein. So this is important, all right? The risk for developing spontaneous thrombi is related to several factors referred to as the Virchow's triad. Injury to the blood vessel endothelium, abnormalities of blood flow, and hypercoagulability of the blood. That's another one. Take out the role of estrogen. We don't care about that. So you have a damaged vessel. You have abnormalities of flow. What does that mean? Is it super viscous? Is that what it is? Or do we have a lot of stasis? Like, is it static? Is it not moving? Right? And we'll talk about some conditions where the blood is not moving much. I don't remember what chapter that is. We talk about this a lot later. So this triad, the thought behind it, it's got to be the circulatory system chapter. It's got to be that. And I don't remember when we do it, but we talk about this a lot. So injury to the endothelium, abnormalities of flow, and hypercoagulability. Because obviously if you have more platelets, more coagulation factor, more whatever it is, if you have more propensity to clot, then you're at a higher risk for a thrombus, right? For example, I have a factor 2 mutation, right? So if I sent you that horribly complicated video that I was telling you about that you don't need to know all that, there's lots of factors that go into clotting, your clotting cascade. And I have a mutation on my second factor with my second factor. So at any given time, I'm 2 to 3 times more likely to throw a blood clot than anybody else who does not have that, right? So I'm hypercoagulable any given day. So if I had some alteration in blood flow and potentially some injury to the endothelium, well, I have a huge opportunity for a clot to form, right? Trying to think what teaching things out of this last. I want to go to a little bit of skin, so I feel crushed for time here. And we haven't even done 22. There's no way we're getting to skin, guys. There's no way. Let's go to 22, if you guys are okay with that, since we have 15 minutes. And there's 5 questions in here, and that's a lot. A lot of times the pediatric chapters aren't a lot, you know, so disorders of erythrocytes. This is, I'm on page 554. She pointed this out that the iron deficiency anemias are mentioned in both, but they are the same, because remember, iron deficiency is our most common anemia in the world, right? And we already went over the people that affects, paraphrasing: poverty, children, especially children with parasites, right? Pregnant or childbearing age women, lead, people with high lead exposure, right? The iron deficiency anemia is a problem. So remember those things. It has to do with how much blood you're losing, possibly, right? Your output, and then your input of iron. But she pointed that out. Okay. I know she mentioned hemolytic anemias of the fetus, but it was kind of in passing. So the big thing with that would be the mother's blood type and then the baby's blood type, right? How can we put this? So the big thing with this, I shouldn't paraphrase because I haven't studied this in a long time, with the exception of this, but with hemolytic disease of the fetus and newborn is if a mom is a negative blood type, like if I was B negative, right? And then I had a baby that was whatever positive, and somehow the baby's blood comes into contact with mine, my body's going to attack that positive, right? This is especially a much bigger problem for second pregnancies, which include after a live birth, stillborn, or a miscarriage. So anytime, because you're sensitized to it, your first exposure, you get sensitized. Really? Probably in OB you guys are going to do this, right? But I think that's next semester. So what your book says is ABO incompatibility occurs in 20 to 25% of all pregnancies, but only 1 in 10 cases results in this. Yep, you got to get a RhoGAM shot. That's exactly it. And I don't remember when you get that shot. It says only 1 in 3 cases is caused by Rh incompatibility. Most cases are caused by ABO. So it can be either one. It can be the blood type or it can be the Rh. Okay, so when do you get the shot? Because that could be a teaching point, right? Yeah, there's a certain mark, and I just don't remember. Death can occur as early as 17 weeks, so maybe it's a little earlier than that, right? Than the I don't know why 10 weeks is in my head, but it's total guess, so don't write that down. And as always, if your book doesn't say it, it doesn't matter. Is that what it says, Shannon? Treatment lies in prevention, ROGAM. Maybe you have to get it at the very beginning. I don't know. I don't know. Sampling is at 8 to 10 weeks. It could be, but it doesn't specifically say anything. So you guys have the right thought process going for sure. This is obviously something that can be fatal to the child with an early demise or a stillborn birth. Okay, let's go to sickle cell. Is that what it is? Okay. I was going to say it could be, but I don't see the numbers for this. So as long as you know what it is, right? So we have talked a lot about sickle cell. This is also where the thalassemias are. Remember the big thing. So sickle cell disease is a group of disorders characterized by the production of abnormal hemoglobin S. So when you see HbS or hemoglobin S, you know we're talking about sickle cell, right? Remember, whenever there is deoxygenation, dehydration, so some sort of stressor on the body, these little red blood cells, they elongate and they form like a sickle shape, right? So that's where you get the sickle cell. So I believe when we were reading before, the big thing was deoxygenation, right? Deoxygenation, dehydration, those are two really important things that we need to always address. Big teaching points there, staying hydrated and um, avoiding opportunities to deoxygenate. How funny does that sound? But any stress where somebody's short of breath or anything else, or higher altitudes, right, where there's less oxygen. Obviously, if you know you have sickle cell, climbing Mount Everest may not be the best idea for you, right? I actually think that years ago there was even a football player. I don't remember this. There's a football player who went to play with his team in some high elevation. And so from the high elevation, the lack of oxygen, and obviously the stress of the game, like I think he went into crisis. Am I making that up? I'm pretty sure that happened years ago. Okay, so there's lots of different sickle cell illnesses, right? It's autosomal recessive. So that's where a lot of the genetic testing might come into play. And she talked about genetic testing for quite a few things. Um, you know, do you guys both have this trait? Maybe you don't know your history. It's always good to check. And then of course Shannon was giving us some numbers from sickle cell also of when they might do the sampling. Um, sickle cell anemia is the most severe form, and then sickle cell trait. So the child inherits it from one parent and normal from the other. Is a carrier state that rarely has clinical manifestations. Um, and then I talked about this last time. I highly doubt this is on your test, but I do find it interesting that this was actually an adaptation to malaria, high malaria areas in people. People who had this trait were better prepared to survive malaria than ones who did not. And I don't remember where that is. You don't have to know that really. Sorry. Okay. So under patho, it even starts to say it's usually causes no problem with when properly oxygenated. So there's what we were saying earlier. Oxygenation is huge. Getting hypoxic is a problem. So you can imagine when people get sick and they get really sick, and you have hypoxia for whatever reason in the body, it's going to have this chain effect, and it's going to affect lots of different organs, which we'll talk about. So your book says oxygenation, pH, and dehydration are the big deals. They all increase sickling, oxygenation being the most important. Whenever the blood cells start to sickle, there's a huge increase in viscosity. Okay, so a big problem with that is going to be hemolysis in the spleen or becoming sequestered there. We're going to talk about this on the next page, actually, with clinical manifestations. Always remember that sickling's not permanent. So once there's the problems are corrected, then they can actually come out of crisis, but there can be permanent damage. All right, so those cells can actually change back. But it does give a caveat of irreversible sickling can occur in sickle cell disease occasionally. Okay. So clinical manifestations. Manifestations are similar to hemolytic anemia. So pallor, fatigue, jaundice, and irritability. As odd as that irritability one sounds. So some of these are kind of generalized, but irritability I don't think has been on any of our other anemias. So sickle cell anemia, I want you to notice that pallor, fatigue, jaundice, and irritability. Okay. And occasionally they can go into crisis. So here's the crisis. Vaso-occlusive, which is thrombotic, right? So this is the sickled cells end up obstructing, and then there's vasospasms, okay? Your book calls it a logjam effect. This can happen in organs. This can happen in different just vessels in the body. This can happen in the brain. This can happen anywhere in the body, all right? So what your book does, and once that happens, I want you to think back to chapter 4 when if there is a logjam, then there's going to be ischemia and hypoxia, right? There's no oxygen getting to those cells. They are hypoxic and there's no blood flow. It's ischemic, right? So ischemia and hypoxia. So then we can infarct, which is permanent. Infarction is permanent. And we'll talk about more of that in cardiovascular as well, now that I think about it. So vaso-occlusive crisis is extremely painful, may last for days or even weeks. And it goes on to kind of reiterate what I said, that in the brain it can cause a stroke, and if it's in the kidneys, it can cause end-stage renal disease. So having a crisis now could affect the rest of your life, right? So you may go in and out of crisis, and then you get this one and it affects your kidneys, and now you're a dialysis patient for the rest of your life. Sequestration crisis. So remember, we've talked about how vascular the spleen is. The liver is also very vascular. They say this crisis is only in the young child, and the spleen for a young child can hold 1/5 of the blood supply at a time. And of course, if 1/5 of the blood supply is in the spleen and whatever else is in the liver, then you're hypovolemic. You have circulatory collapse that happens, right? Cardiovascular collapse. Aplastic crisis. So this is diminished erythropoiesis despite a need for new erythrocytes. Okay, so when you see aplastic, that's what you should think of. So the erythrocytes in sickle cell only survive 10 to 20 days. And so even though they need these cells. There's just not enough production, and the sickled ones, the damaged ones, are dying and being taken out. And then hyperhemolytic crisis, which of course is destruction of the cells, right? Since we're ending on this, let me just look. So they do newborn screening for sickle cell, depending on state law, it says, because obviously you need to prepare for care for that child if you find out that they have it. And then hydroxyurea is a drug that inhibits DNA synthesis and has an anti-inflammatory effect. We actually use that drug for several different things, this being one of them. So supportive care if they go into crisis, and also we want to prevent that. So there's a lot of teaching that could go with sickle cell if someone has a child with sickle cell. So the thalassemias, I know we spent a little bit of time on this the other day. The big thing about thalassemias, so in grouping them together as alpha and beta, the first sentence here, inherited autosomal recessive disorders that cause an impaired rate of synthesis in either the alpha or beta chain of adult hemoglobin. So that's the big problem, impaired rate of synthesis in the hemoglobin chain, okay? I don't know if you'll need to know where they come from, but for me, I try to remember it with alpha Asians. She did mention who? Okay, good. Well, then I don't feel like that's a total waste, right? Alpha Asians, so the alpha Chinese, Vietnamese, Cambodians, Laotians, right? Alpha Asians. Beta is the other people. Like I don't have a thing for that. Beta, Greek, Italians, some Arabs, and Sephardic Jews. Um, Trying to think of what else to summarize. Oh, of course, we're out of time here. So what I would do, guys, since we're ending kind of in the middle of this, remember our chart is on 514. So for that table that I was talking about making, if you are doing it, if you're not, that's fine. But the thalassemias are mentioned on here. It says impaired synthesis of alpha or beta chain of hemoglobin. Come back to page 561 and pull out your thalassemia information. You know, pull out what the clinical manifestations are, the big things, right? And then if looking at evaluation and treatment, is there anything that you could pull there for teaching? I don't know, but that's what I would do. Just add that to the table that we've been pretending to make or making or whatever. You know, pull out your stuff. I would go ahead and also I would look over your hemophilias a little bit. Hemophilias, you know, the thing when we get to leukemia is that a lot of the leukemia and lymphoma is repeated, right? See you later, Shannon. Thanks for coming. So that'll be a refresher. So other than what we've reviewed, you really have hemophilias left to just take a look at, and then leukemia and lymphoma is at least to do at least you've seen it already, right, with the adults. But of course, if it's in both sections, to me, that's always a red flag to pay attention to it. I'm sorry that we're not reviewing the skin stuff again today. I feel like that was probably our second biggest need because we spent a lot of time in genetics. But remember to group your questions. Group your disorders in genetics, like we've talked about, right? Remember in skin, we went over a lot of stuff, but on those tables where it's showing you the pictures of the wheals and pustules and whatever else, vesicles, if you can relate them to some of the skin disorders later, it'll kind of help you to connect, right? I feel like she might have started talking about rubeola, rubella, that table at the top of one of the pages. I'm not sure. And I don't have time to look. I have to go make dinner now. But if she mentioned that, I saw that, the TB test. I think, I could be wrong. I was just listening and not writing because I was doing something earlier. She may have started to mention the childhood diseases one, and if she was referencing a table that compares, I think varicella might be on it, but then rubeola, German measles, and the red measles. If she is talking about that table, the way that I differentiate some of those in my mind, if she's talking about that table, don't even worry about it if she didn't mention it, but is the appearance of the rashes maculopapular versus macular. You'll see what I'm talking about if that's a table she mentioned. I'm sorry we didn't get to it. I'm just doing things off the top of my head. To look at the hemangiomas, what's from birth, sorry. What else? What else was sticking out to me? Let me see if I wrote anything else down for you guys on this. I don't think I did. And again, just read the questions really carefully. You guys have got this. You know what test one was like. This is a little bit different, but you kind of have an idea. And if you don't know it, as always, just cross out what you know it definitely is not. Look at your prefixes and suffixes. What else did I want to tell you about the skin? I can't remember. But if you guys have questions or something gets to be foggy, you can email me and I'll always try to respond. I work the next 2 days for sure, but as you guys have seen, those of you who have to email me, I'm usually pretty quick in responding. So good luck. I can't wait to see how you guys do, and I'll see you on Thursday, okay? You're welcome. See you later, guys.